All right, good morning. My name is Navid Emrabadi, and thank you, Stephen, for the introduction. The whole idea of this talk is basically to start some basic basic conversations that you may need to have with your patients. I would like to sort of look at this at sharing my toolbox with you. I'm sure you've probably heard most of what I'm going to talk about before, but the whole idea is, as we going through the objectives of this talk, is to know about these tools, and then it's up to you when to use each tool for each patient. So we're going to talk about basically a patient or an approach, how to have a patient-centered conversation, and actually how to respond to their emotions. We're going to touch on the socio-psycho-biomedical model of pain and the role of thalamus in a very simple way. And then, as you've probably heard, opioids are probably just the important area that we definitely need to touch on when it comes to acute pain management and persistent pain management. And then we'll try to wrap it up, about some very common misconceptions about, what they can see on X-rays and MRIs and actually what they really experience. So, well, I think the first step for any clinician when they try to change a behavior, when they try to start a conversation, is basically to establish rapport with patient. And I'm assuming that if you see someone with pain and being on lots of medications, the first thing that crosses your mind is, how can I help this patient to understand that he or she may not need this much medications, or how would I be able to actually reduce his or her medications in a safe way? But the biggest problem that we usually face is, they can be very, very actually reluctant to listen to you, or they can always come up with lots of excuses. They can all of a sudden become angry, they can become frustrated, and the natural response is we always try to explore, why are you so upset, why are you so angry? Well, this is my acronym, and this is well examined in the past, and many practitioners actually use this. This is probably just the easiest and the quickest way to respond to your patients, and that I have found actually a very, very useful way of establishing rapport with patients. So when you see a patient, the first thing for me would be to name their emotions. So if they're angry, if they're frustrated, I can just start by saying that, well, you seem to be a bit frustrated, or you seem to be a bit angry, rather than asking them, why are you so angry, or why are you so frustrated? And then the next step for me would be to show some understanding. Well, it's understandable. You're in pain, no one has listened to you, or whatever. And then it's always good to respect them and support them. And then they will be ready to answer your questions. So I would probably just use this as one of my most valuable tools, to start any conversation with my patients. Well, moving on from there, as we just actually touched on, the emotional side of any basically problem is probably as important as the biomedical side, and of course, the environment that the patient is in. So it used to be called basically biopsychosocial, but now actually they would like to make the social side very, very important. That's why I put it on top. So now we're looking at the socio-psycho-biomedical approach to pain. When you see a patient with lots of pain and lots of medications, they have probably heard in the past that the environment they are in, or the psychological side of of the pain, they all play an important role in their experience, about pain. But not many people would accept it, or at least they would take it with a pinch of salt. One of the ways that I usually use is I just start sort of drawing, some simple drawings, and just tell them, look, if you've got a sore back, the pain signal travels through a nerve to your spinal cord, travels all the way up to the entrance of your brain, and then they just, sort of try to imagine the pathway, and then tell them, at the entrance of your brain, there is something that some doctors would like to consider as a pain gate. Just imagine swing doors, the pain signal goes through, it actually kicks in the gate open and travels all the way up to the brain. And one of the things that I always tell them is, if you've had pain for a long time and all these signals have been kicking open the pain gate, after a while the gate stays open. That's something that they can relate to. And then I start talking about, that the nerves that carry pains, they can start sprouting, and they can make links with other nerves like temperature nerve, like movement nerve, touch nerve, and no wonder people with persistent pain, when it gets cold, they start feeling more pain, because the temperature signal, rather than traveling through the other pathway for temperature, which is probably like a dirt road, it tries to jump over to the highway of pain and travels all the way up through the open pain gate, and they experience pain. Does it make sense? And I think most patients can somehow relate to this. Well, this is probably a very oversimplified, way of describing what's really happening. But I found it actually really, really helpful. And when they start asking about this pain gate, I just ask them, look, to sort of imagine it as you can see, like two swing doors here. I'll tell them the gate actually is really sort of there, and it's a part of your brain called the thalamus. So again, this is a very oversimplified, way of saying things. So one door deals on the outer side, lateral side, and we're talking about actually lateral, pain pathways. It deals with the location and intensity of pain. And the other side, the medial side, deals with emotions, sense of danger, suffering. So one of the examples that I usually share with them is, imagine you just getting a good massage. The masseuse, pushes your back, and the signal travels all the way up to your pain gate. The pain gate, the lateral side says it's coming from your back location. It's 5 out of 10 intensity, and the other side says, well, it's nice, it's a massage. So what happens is, combined together, the 5 out of 10 pain may be dialed down to 1 out of 10 by the time it gets to the cortex. So this is scenario number one. And the person sort of walks out of the massage shop, and all of a sudden someone runs by and punches him in the back. So what happens is, again, the signal travels all the way up, and it's still coming from the back. The intensity is still 5 out of 10, but this side tells the pain gate that, why did he punch me? All the anger, emotions, everything kicks in. So the number gets dialed up from, let's say, 5 out of 10 to 9 out of 10. So all of a sudden, there's excruciating pain in the back. So, they usually, patients, they usually relate to this example. That's I found an easy way and a good way of explaining what they have experienced in life, how the current situation can affect their pain. So when it comes to, by saying all of this, we're kind of preparing patients for the next level, and that's when we're talking about management. Most patients are kind of really concentrating on the fourth and fifth sort of steps of the management. Well, by showing them this kind of approach, I tell them, look, I acknowledge that medications, they have a role. We acknowledge that, procedures, they have a role. You may really need a surgery, you may need a procedure, but it's important to address the other aspects of pain. So I usually start with education, and then we talk about physical things that we can offer them, like physiotherapy, like orthotics, referring them to a podiatrist, whatever. Psychological, they may need to be educated about how to sort of do meditation, how to do relaxations, how to sort of learn to distract themselves from pain, and eventually we talk about medications, and again, well, it's very important to sort of talk about all different aspects of pain management. One of the things that, just moving to the next tool, one of the other topics that you may need to talk to your patients about is about goal setting. Well, I could talk about like more sophisticated stuff like how to set a goal, like the SMART approach. But I thought, one of the very basic things that we always need to remind our patients is while we would like the pain to be less, it's important to aim for function improvement. Sometimes patients, take medications, then they always tell you, oh yeah, when I take Endone, when I take oxycodone, when I take this or that medication, my pain score actually improves. But then when you ask them, all right, does it help you to do more? Does it help you to drive? Does it help you to walk? Does it help you to do anything around the house? The answer is no. They just take the medication and just lie on the couch and watch telly. And that doesn't really help. So my approach would be, as much as I would like your pain to be less, I would like you to be able to do more. And that would be probably the best guide as how to titrate the medications. So far, any questions? No? Oh, you'll have time to ask questions. And I think one of the important things that I would like to basically share with you is, you've probably seen patients with a big pile of X-rays and CT scans and MRIs, and they're doing their best to convince you that their doctors don't understand their pain, and they've said that there's something very wrong with their back. They've got all these changes and they slip discs and everything, and they try to sometimes they try to convince you actually to write to the doctor to increase their medications. Again, one of the tools that I would like to share with you is, what I usually tell them is, imagine you go to a doctor and this doctor pulls out a very, very expensive camera, I don't know, 200 grand worth of camera, and takes a photo of your face, okay? And then sends the photo to somebody else, a specialist, and the specialist starts writing a report on the features of your face, about all the wrinkles, all the dots and spots that you've got on your face, and you're seeing the doctor for your headache, not for all these wrinkles. And then all of a sudden, this doctor with the report refers you to the third doctor, and the third doctor offers you to have some surgery on your face to get rid of all these wrinkles, and then there's a good chance that your headache's gone. What would you do? Well, most patients would say, no way, I would not do that, because wrinkles are signs of aging, and I don't want to go under the knife to get rid of my headache. That's the point. We all age inside out. We can see wrinkles on the outside, and we get some sort of wrinkles inside, whether you would like to call them, bulge discs or whatever, they may or may not sort of correlate to your pain. I thought, as much as I wanted to avoid actually sort of getting into details, I thought it's worth at least just mentioning a study. Actually, this is a systematic review done in 2015, so it's not that many years old. And as you can see, for example, in people in their 20s, about 1/3 of them, on MRI, they have bulge discs with no pain. I'm talking about people with no pain whatsoever. So actually, they actually grabbed this bunch of volunteers and they paid them and they did MRIs on them. You can see, in the 40s, about 70% of people have this degeneration. So all the people in this room, in the age of 40, if you've never had actually any pain in your life, there's a 70% chance that if you had an MRI, someone could find actually a bulge disc on your MRI. And as we get older, the percentage goes up. So what you see on X-ray or MRI may or may not correlate to your pain. And I think that's a very strong message that it's important to share with our patients. Well, this is probably just my favorite slide. Not this one, this one. I have come across, very smart clinicians, and they try to explain things to their patients, and they just, sort of bring out like a very nice, slide, something like this, and they try to sort of explain all these pathways to the patient, and then at the end say, well, is there any questions? And everyone just looking at them say, well, no, not really, So this is my version, okay? What I tell my patients who love their opioids is, look, opioids are designed to numb your nerves, okay? So that's not a bad thing. You take opioids, the tiny molecule of morphine or whatever comes and sits on your nerve. And as a result, well, the nerve goes numb. So far, so good, so you don't get as much, pain signals transferred through the nerve. And as a result, you get less pain. But that's not the end of the story. These poor nerves cannot feed themselves. They are fully dependent on these tiny feeding cells. Whether you want to call them feeding cells or glial cells, it's up to you. But imagine those, molecules of morphine, they come and sit on these feeding cells. As a result, they go numb as well. All right. Well, the best way is just talk about, glial cell activation. But this is my simple way of explaining things to patients. So when they go numb, they stop feeding your nerves, and the nerves become very agitated and angry. As a result, even if the initial injury is gone, you're dealing with a vicious cycle of bunch of hungry and angry nerves and cells, and the pain lingers forever. The only way out of this is basically just to reduce the numbing agent, which is your opioid. And as a result, these feeding cells, they start picking up, they start feeding themselves, they start feeding the nerve, and hopefully your pain will be better. So rather than going through this is my simple explanation for patients, and I've seen like amazing results, So then the next question they usually ask me is, what about this medication I'm taking? What about that medication? And you can talk about lots of side effects, and they don't really buy it, But if you tell them that actually what you're taking this way can increase, your pain, well, then they may start sort of thinking twice about taking their medications. We try to sort of briefly go through role of opioids in acute pain. I think the message we should always remember is that opioids are valuable. They are good medications, if you use them for the right patient. So it's not a black and white, concept, whether they're good or bad. They're good for the right patient, and they're not good for the wrong patient. So I think one of the important things to remember, and that's actually based on the recent statement of Faculty of Pain Medicine, is when you're dealing with opioid naive patients, it's best to avoid prolonged use of sustained release opioids. So starting them on something like OxyContin or Targin and carrying on because they've got a little pain is probably not ideal. Some people can go to the other extreme and say, no, I'm not prescribing any long-acting opioids. Well, I think it goes back to the doctor and to the patient, and there are assessment tools to see whether the patient would be at risk of actually some problems down the track or not, and I think we can just leave that to the prescribing doctor. But I think for most clinicians, particularly pharmacists, it's important to sort of like, see a red flag if a patient's still on some opioids, like 6 months after a surgery. For people who have been on opioids in the past, I think it's important to continue the background, long-term opioids, whatever they have been on, and then sort of use other tools, whether it's a bit of short-acting opioid plus all the other 5 areas of pain management. That might be the way to go with them. And I guess when we use opioids in persistent pain, and I guess that's a big part of what some of you do. It's good to remind our patients and remind ourselves that there is no long-term benefit, from opioids for persistent pain, and it's important to avoid immediate release formulations like codeine, endone, for patients with persistent pain. It's always good to use something else to reduce the amount of opioid, whether it's a bit of duloxetine, whether it's a bit of endo, whether it's a bit of pregabalin. That's always good to consider. And these 5 A's are very, very important to check every time we see someone on long-term opioids. So we need to check their activities. We need to check the level of analgesia. It's important to make sure they're not showing any signs of any aberrant behavior. We always need to check for any adverse effect, and of course we need to check the mood and make sure they're fine. Any thoughts to share? Any questions? Yes.
What sort of aberrant behaviour do you see?
Oh, all sorts of it. No. Well, they lose the script. Someone comes and steals their medications, or any kind of things. Now, they just do doctor shopping. They can become a bit aggro when you try to change anything. Yes, please.
What's your experience with Pentadol, like Plexia?
Well, it's a good question. I'm not sure if any of you were for the Plexia talk, just 2 nights ago on Monday. Honestly, well, I'm not sure whether I should share this with you. It seems to be safer than pure mu agonists. I think we're still in early days of using Plexia, so it's probably a little bit premature to sort of say it's all good. But my experience, I haven't really seen much problems with Plexia. Some people purely don't like it because they enjoy having the highs from mu receptor activation, and Tapentadol is not doing it as much.
They're usually on too much of a dose. They're getting a high, aren't they?
Well, it's not about dose. It's about where they work. Tapentadol works on a little bit on mu receptors, but more actually on the noradrenaline pathway and activating descending inhibiting pathways as compared to more pure mu agonists. And that's where they get side effects and get the highs from. So, yes, please.
I thought maybe Tapentadol might have a place in therapy in people who get a lot of opiate-related itch and histamine relief.
Absolutely. Usually, most side effects of opioids coming from actually activation of mu receptors, and the fact that the affinity for mu receptor is probably about 5% for Tapentadol as compared to, or to be exact, 7% for Tapentadol as compared to morphine. So 1/18 of morphine, you would expect to have basically the same level of side effects with Tapentadol.
So do you see people getting any opiate-like itch or rashes or that sort of thing with Tapentadol at all?
Oh, I haven't seen any. What I have seen is some people can go into withdrawal because so that's the problem. But I guess it's important to titrate the dose and maybe just keep them on a little bit of opioid while we're tapering. someone from there just so. No? Yes, please.
I'm a single. I work with a lot of very older patients,
Mm-hmm.
and it's common to see pregabalin prescribed with the opioid
Mm-hmm.
resistant pain.
Mm-hmm.
There's more and more research sort of coming out questioning that.
Mm-hmm.
What's your opinion of combining?
Well, it's not more about my opinion. It's all about the body of sure. It's about the body of evidence. They've done some studies. The probably out of 14 studies, there was actually a systematic review. I think it was like 4 years ago, and well, out of like 14 or 16 studies, there were only like 2 or 3 of them that could just sort of like have show meaningful improvement. But the common belief is that they can actually reduce the need for opioids, and the number of studies that they've shown that they can be helpful. We were dealing with like a small group of patients and with particular types of pain, usually post-op pain. But at this stage, this is the common practice. So you prescribe other adjuncts to hoping that you can reduce the need for opioids. And if you could get that, great. If not, well, I don't know. Last year, the American Academy of Pain Medicine annual meeting, I think there was a recent actually double-blinded study showing that pregabalin actually doesn't really reduce the post-op pain and opioid need. But that's just one study out of many. And I think the common belief still is that if you use pregabalin, that you can reduce the amount of opioid needed. Yes, please. Yes.
Just wondering, in the elderly, say, non-neuropathic pain,
Uh-huh.
what sort of medication would you go for? I know that is probably the least important out of the whole spectrum. What would you use?
Sure, it's a good question. I would like to sort of go back to my basics. So I always look at all the other aspects of management, like education, if there's anything physical we can do for them, and if there's any psychological aspects we need to address. When it comes to medications, basically it depends on what kind of pain we're dealing with. If you're dealing with a bit of osteoarthritis, perhaps after doing all the other things, hydrotherapy and everything, maybe a bit of panel osteo, we can try. We should never forget that glial cell activation and pushing patients, from actually an acute pain into actually a persistent pain state with neuroplastic pain is probably just the biggest pitfall we should try to avoid. So if you're asking about the opioids in particular, I would try to make it as little as possible, being mindful of all the side effects and look, it depends. Most patients that we see, they're already on something. If we could change them from a high dose of pure mu agonist to something with less affinity for mu receptors, such as tapentadol or buprenorphine, I think that would be a good move. All right, thank you.